Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, filling in for Dr. Steve Stites this morning, who is occupied by clinical duties. We're coming to you live from the Dolph Simons Jr. Family Broadcast Studio, and the Secretary of the Kansas Department of Health and Environment, Dr. Lee Norman, is with us again for our weekly update on vaccine rollout across Kansas. But first, Dana Hawkinson, our Medical Director of Infection Prevention and Control, is here with our numbers. How do things look this morning?
Pretty good. You know, we are, keeping around that 70 total patient number. Our acute infections number has been kind of bouncing around from low to mid-30s to mid-20s. Right now, we have 28 acute infections in the hospital, with 9 of those in the ICU, but only 3 on the ventilator, so that's always a good thing. Still have 42 in that recovery period that are still in the hospital with 3 on the ventilator. So 70 total, which, is livable. We certainly would like it less than that, but I think we're doing okay as far as that goes. Hays is doing pretty well, too. 12 infections, 7 of those in the acute phase, 5 in that recovery period. So they are doing pretty well as well. For them, certainly they have a smaller census or population, so higher numbers, even a little bit higher numbers, can really affect their capacity. But overall, we're fairly happy and optimistic about what our numbers here at the health system are.
Yeah, I would agree. Let's head right over to Dr. Norman. Good morning, sir.
Hey, good morning, Dave. How you doing?
Doing well, thanks. What would you start out with sharing this morning about either vaccines or infection rates in Kansas? I know there are some news stories on both fronts today.
Yeah, actually, there's continued pretty good news overall. The rate of decline of the incidence of cases is encouraging. Let me start, though, with, curiously, weather. The delays in this deep cold is delaying the federal government in shipping some of our vaccine to us this week. Mostly it's stuck with FedEx and I think upstream from us. So there'll be a delay of the Monday, Tuesday vaccine probably won't arrive till Wednesday, Thursday. So we are dependent to a degree on Mother Nature, and we'll catch it up. A couple things overall. One is, and you guys mentioned it before the start of the show, is that the UK variant, we do have a second case now in Sedgwick County, a young man who did travel out of the state. And not much more to say about it other than that right now, except to say that we are getting the feeling that it will become a dominant strain because it is more infectious and people really can't let their guard down. There's no connection, by the way, from an epidemiology perspective, between the earlier case in Ellis County and the one in Sedgwick County. So I'm sure there's going to be pockets and spread in local regions. It also emphasizes the importance of getting tested. Anybody that gets exposed or has any illness symptoms or even just wants to get tested, go to the gogettested.gov/Kansas. Actually, it's gogettested.com/Kansas to find out the testing sites nearest to you. We've been rapidly expanding the amount of testing in many different areas. We're, I think, right around 2.5 million tests now having been performed in the state of Kansas, and it really helps us from an epidemiology perspective. The numbers, Dr. Wild and Dr. Hawkinson, are good. They're good compared to what they've been in recent months. Yes. Let me put it that way. On Monday, we reported 1,348 new cases. That's 3 days since last Friday morning. So what is that, 400 to 500 cases a day, which is markedly less than the 1,000 to 2,000 cases a day. That brings our total to 287,450 cases that have been recorded for the state of Kansas. I'm sure that's a low number. 42 deaths recorded again on yesterday morning, a low number, brings the total to a sobering 4,406. And as you guys know from where you are in the hospital, and this is true all over, is we only had 36 new hospitalizations in that 3-day period. So that's been encouraging that the numbers are going the right direction. We've now had, as of yesterday, 572,000 doses of the vaccine, both the prime and the booster doses. Almost 400,000 of those have been injected into people. Let me rephrase. They've been recorded as being injected into people. We know that's a low estimate. That's right at 70% of the vaccine as having been recorded as being administered. We know that we're still struggling with this, with all these new vaccinating sites. There's lots of new interfaces with electronic medical records into the state system, and then the state system automatically uploads it to the CDC. This is not unique to Kansas, it's everywhere. We have about 70% of the doses recorded as having been administered, and we know that's low, and we're doing some workarounds and trying to make sure we keep an accurate number. We are encouraging, obviously, vaccinating sites not to store any vaccines, but to get it out, put it into people's arms right away, and then the data will catch up. So it's a little disarming for people to say, where's the rest of that? Is it sitting on shelves? And the answer is no, the vaccine is not sitting on shelves. There's a little bit of that until their next vaccination clinic, for example. But overall, it's getting into people we know because we call them and talk to them on the telephone about it. So that's kind of the broad stroke update, Dr. Wild.
Yeah, I'll maybe start where you landed there. I think, we've worked with your team at KDHE on answering some of those questions. How are doses moving from the supply chain perspective when they're delivered, and how long does it take to get a dose in an arm after it's here? And I think we've heard from many other clinic sites that are administering vaccine that the goal is to have vaccine in arms within days, and never really to hold a vaccine for more than 7 days from when it arrives to when it's administered. And I think that's consistent with the plan at the state level and even the national level, that we don't want these things sitting on shelves. And we've been lucky; we've not had that problem here. One of the questions I'd ask you on the vaccine front, if we stay there for a minute. The governor had mentioned on Friday that we could expect 90,000 doses to the state this week, and that's an increase of nearly double from what the run rate had been a few weeks ago.
Right.
We've heard a bit from state and county officials that part of that number is due to an administrative change, just counting 6 doses per Pfizer vial instead of 5, but that's not the bulk of that change. So where are those doses coming from, and can we expect that that is a continued increase in supply going forward?
Yeah, great question. You're exactly right. The Pfizer, by getting 6 doses per vial out of a 5-dose vial, allows for some of that, but the bulk of that is new coming into the distribution pipeline. And yes, we can expect, we've been told to expect it to continue with at least that run rate. We're trying to always have a 3-week window of visibility into the future. So it'll actually be more than that, I think. I didn't mention the National Retail Pharmacy Program started last week. That's a program run by the CDC where there's lots of pharmacies, and you'll know a lot of the names with CVS's and Walgreens and Dillon's and Walmart's and the some big retail, but also the consortium of smaller community pharmacies too. So Kansas, last week, 82 pharmacies received vaccine, not a whole bunch. 9,000 doses went to 82 pharmacies, so 100 and some doses per each if it was distributed evenly. I think the CDC, the message on a phone call last week with them was that they wanted to kind of make sure they could walk before they could run, to test distribution channels to make sure that it's working well. The pharmacies, we heard from a lot of them saying, how come we didn't get more than that? And that's just what comes into us from this. It doesn't actually come to us at all. It goes right directly to the pharmacies from the CDC. But hopefully it'll be that 90,000 plus an ever expanding number coming in through the retail program and the retail pharmacy program. And I think we can expect that for the longer haul. There's always controversy about distribution. Everybody wants more vaccine. And all we can say is, yeah, we do too. we want as much to come to us so we can push it out as quickly as possible. We have over 1,000 vaccinating sites now. It wasn't just a few weeks ago when we were talking that we had about 350 or 400 that were actively vaccinating, mostly, and you know this, hospitals, local health departments, and federally qualified health clinics, centers. But now we've got over 1,000 registered vaccinating sites. We haven't had to turn them all on yet. You can see where those, you can see, as a matter of fact, on our website, on kansasvaccine.gov website, you can even see a spreadsheet that has the location of all the pharmacies. In addition to that map that just scrolled by with the dots, those are the vaccinating sites throughout the state. So that it's getting populated with more information. It's a little ungratifying because it's still hard in some settings to get a vaccine just because it goes out the door so quickly and into people's arms. But we're optimistic about this, the the National Pharmacy Program is incrementally bringing more to us because that also, especially with the small community pharmacies, has a real advantage is that gets into rural communities that might be their provider, if you think of it that way, in a very small community. So it helps to distribute it into the most remote or frontier sites as well.
Yeah, you mentioned the challenges around distribution and the fact that no one's ever happy with how doses are going or where they're going and the quantities. There's been a decent amount of talk about the differences, say some rural counties that are vaccinating well outside of phase 2, at least by report, when there are other suburban or urban counties that feel like they can't get enough dose for phase 2. I realize that there's a lot of nuance in each of those situations. Do you have thoughts about how we can better balance that if there becomes less uptake or less demand in some counties while there remains higher in others?
Yeah, well, first off, I think it's a fairly small problem overall. The county that made the newspaper the other day has 100 doses a week. And if they're opening up beyond phase 2, they're not opening very far beyond phase 2. I realize it's a small rural county with, I don't know, maybe less than 2,000 population, I don't know. But that's not the goal. The goal is not to go beyond phase 2, but to load level across the state and to move through relatively orderly. Now, of course, if there's a few doses left over, fine to give it to anybody that really needs to have it. That's not a big issue. But it's always, and then we won't supply the counties that are done with phase 2, then we'll shift all those doses to some other county because we want all the counties and all the rural and urban areas to move through in an orderly manner. Because we didn't just pull these phases out of the air. They are based on how risky it is for those people in each phase. Phase 2 is more higher risk than phase 3, et cetera. So this is not arbitrary. It's been very well thought out. So we don't want advancing into phase 4 and 5 when other counties are still squarely and maybe hundreds of thousands of people behind in phase 2. If you think about just the numbers, and I know you're a numbers guy, to have 1 million, let's say we have 1 million people in phase 2, and let's say we have 100,000 doses a week, just for easy math, that would be 10 weeks to get through phase 2. Now that's assuming a lot of things and the even distribution, the things we've talked about, but that's about, there we go, the phase 2 right now. So that's what we are that's where we're kind of coming up with the numbers and the expectations as to when people can expect to get the vaccine.
If we pivot for just a second from the vaccine back to a couple of things you mentioned around variants and testing. First of all, you mentioned the increase in number of testing sites and the ability to build a network to continue to test because that will remain important. One of the questions that we get a lot, specifically around testing and variants, is how many isolates is the state lab sequencing per week to manage or watch for, surveil for variants across the state?
Yeah, good question. We doubled our whole genomic sequencing capability by adding a whole nother platform. And we're doing, at this current time, on just a surveillance basis from around the state, about 350 a week. And that's, the number was chosen because that's the capacity of our testing platforms. We have other testing sites that we do commercial labs on a contract basis as well. Also, we do whole genomic sequencing when we're asked, anytime we get a sample. And we get doctors' offices calling in saying this patient seems to be acting a little different, or we had one correctional facility that it was very fast moving through. So we test those and very specifically with epidemiologic trackers and whatnot, because there's so many different variants already. People, I think, are getting a little freaked out by, oh my gosh, there's a mutant strain. I mean, that's just what viruses do. Dana Hawkinson can talk better about that than I. But it's some matter and some don't, and it's really important to make sure we can isolate the ones that we know that particularly matter. But it's been fascinating. We got this in our incident command report yesterday. We had no active cases in their correctional facilities, and that was a first since in the last 55 weeks.
Yeah, that's worth some applause.
That's great. Yeah.
We know too from watching the cluster report that the number of long-term care facility clusters are down significantly. I think maybe even less than 10 now, which I think is a big shout out to the importance of vaccinating those high-risk congregate settings early in the process.
You know, one other thing I would like to say is that we are tracking all the time, both from a diversity, equity, and inclusion perspective, different racial and ethnic groups, and we're going to start very soon, I think maybe within the next week, putting data on our website. We already have that about testing. And by the way, from a diversity, equity, and inclusion perspective, our testing has been very good, very equitable across all ethnic and racial populations. And ditto that for rural and urban. We're going to do the same thing with vaccinations. An interesting finding, and you guys will understand this perfectly well, is that the vaccines are about split 50-50 of those given to 65 and older and those under 65. And the 65 and older are catching up, as you would well imagine, because the first phase had healthcare people, and healthcare people tend to be less than 65 years of age, present company excluded. But the 65 is catching up now.
You know, we've seen the same thing in our data as we work with local county health departments, for example. Just Johnson County residents, as we've partnered with Johnson County to be a vaccination site for their over 65 populations, while they have focused on over 80 and some essential workers. We know in our clinics alone, we've done over 5,000 prime doses in the last 10 days or so in the 65 and over group. And so that I think is very true. We're seeing a lot of that. If we look at our overall Johnson County population, there was a phase, or there was a sort of a bunch early on in phase 1 that were healthcare workers that work in our facility. And then now it's really pivoted to that over 65 phase 2 high risk group being vaccinated here. Jill, let's see if there are questions from reporters on the line this morning.
I don't think we have reporters that are monitoring right now. They'll watch later. I think everybody's in weather coverage right now, which they probably should be.
It's cold out there.
It is cold.
Which kind of, I'm going to go with Isaac's question because it's sort of related. Isaac wants to know what the contingency plans are for the weather if have delays in shipment and that kind of thing.
Well, Lee, I think you mentioned already, we know that there are delays in the logistics part.
Re-ask the
Can
question.
you hear me, David? I lost your...
There you go. Yeah. The question from Isaac was, you know, what are the contingency plans around any potential weather delays in shipping? You mentioned that we already know there are some. Anything from your perspective that's important as part of that message?
I think it's just going to be a very brief speed bump in the road. Again, if it gets into our state, we're going to push it out. The roads are fine. But keep in mind that so much now doesn't come into Kansas, i.e. to our state agency, and then get pushed out. It goes directly by FedEx, UPS, et cetera, directly to the vaccinating sites. So they were stuck in Memphis. It's really critical. But these transport mechanisms, we have not seen problems with the cold storage, despite the fact that it's kind of tricky. That has not been a big problem. So I would see this just a couple day delay, really. I think we're going to be fine and catch up.
And Dana, clinically, along those lines, we get questions all the time about, does it hurt if my second dose, my booster dose is delayed by a few days or even a week or two?
Right. Yeah, the answer to that is no. Certainly in the CDC guidance, they allow for 4 days either side of that second dose, so 4 days before if you can't, you know, if you know you're going to be out of town or something, or 4 days after. But there's more and more evidence that even delaying that dose, because for one reason or another, to that 6 weeks, 12 weeks is okay. You'll still have that boosting effect, but you really want to try to stay on schedule as much as possible.
Okay, we're going to start with questions in Sedgwick County, and then we're going to go to Johnson and Wyandotte. And I got to tell you, fair warning, the theme is all the same, which I think is interesting and good to hear from all these people. Rachel says that in Sedgwick County, she read or heard that they were short volunteers, had 16,000 doses sitting in storage, that doctors' offices were volunteering to help distribute the doses, but they are being turned down. She wants to know if you could speak to that. And why is Sedgwick so far behind? Which is the same question for Johnson and Wyandotte, just let you know.
I have not heard that there were any problems at all. As a matter of fact, I was just on with Ascension yesterday, and will be again today, with the county health department and with the Grace Med, and according to them, they're not doses sitting on shelves. Ascension and I are talking about whether they want to initiate to assist in the community, but it has not been needed with the amount of vaccine coming to them at this point. So there's that. If that is going on, it's not at all on our radar, and not according to the people I talked to. By the way, I should mention that you may have heard the Biden White House is planning to send directly, in order to get to minority communities represented, they're sending directly to FQHCs. I haven't received final confirmation, but we have 2 federally qualified health centers in Kansas that have been selected, and one of those is in Sedgwick County, I might add. Until I get final confirmation, though, I'm not going to release the names of those 2 entities. The other thing is, and I know that, and I can anticipate what the other questions are, is about why are we in Johnson County, the biggest county, not getting our fair share? Why is Wyandotte, the 3rd largest county, not getting its fair share? And the answer is that we are spreading it on a per capita basis. There's a few counties that get a little bit more. There's a CDC vulnerability index, which talks about how many people live in poverty, how many people don't have access to transportation and the like. So there's a little bit of a bump for those, I think, 17 counties that score high on the CDC vulnerability index, but that does a very minor amount. One thing I would encourage people to do, and because we publish every week, that's what causes controversies, we publish the weekly allocations on our website. If you look from one week to the next, there will be some variability at times, but we work with the counties and we assess, what do you desire to have? And sometimes they'll say, we aren't going to be running a major clinic. Can we hold off next week and only have a half an allocation, and then go 2 weeks from now with a larger to make us whole, quote unquote. So people have to look at it over the long haul to see, because I can tell you that Johnson and Sedgwick County have received the highest allocations all along the way.
And to the question about volunteers and doctors' offices being willing, I think we know here, I think it's true across the state, Dr. Norman, but we know that the problem is not actually in having places to administer the vaccine. There are plenty of options for administration. The challenge remains almost solely with supply.
Exactly, David.
All right, Melissa wants to know, she's in Osage County, and she said they charged $30 to get the shot. She thought the shots were free.
The vaccine is free. A clinic setting can charge an administration fee. I've not heard of $30. The amount that's approved by a Medicare or Medicaid is $15. But there should never be any out-of-pocket expense for this free vaccine.
He says, I read a Forbes article. I'm hearing myself. Sherry said, I read a Forbes article saying Moderna vaccine's antibodies drop off significantly after 3 months in older people. It was a small study, but what are your thoughts on this?
Well, I think we're not necessarily surprised by that. Antibody levels are not the primary marker of immunity. If we looked at antibody levels only to determine efficacy or effectiveness of a vaccine, we would find that this is not uncommon. And Dana, anything to add there?
Yeah, I think that's absolutely correct. First of all, there's no correlative protection with a level of antibody. We haven't determined what that level of antibody is. Second of all, since people have been infected with coronavirus and survived, there have been a number of studies looking at that temporal relationship about the amount of antibodies. I think what's more important is you do have that memory function. So you still have circulating B cells that are able to create specific antibodies if you are reinfected with coronavirus. That's important to know. Also, the other aspect is, just as you had alluded to, there's other things we need to consider, such as T-cell response. T-cell responses are extremely important. It's very difficult, certainly more difficult than just checking antibody levels, to assess what is your level of T-cell responses. One of the main theories, or one of the theories out there, is that, older people are affected more because they do have less of a T cell response as you get older. So when that happens, you can have a lot of damage caused because you don't have that T cell response. So your immune system uses other types of cells, continues to use antibodies to try and defeat the virus and make yourself better. So I think just going with these studies that are looking at antibody levels really doesn't give the whole picture of what is your level of immunity to coronavirus. What we do think is that these vaccines, Moderna and Pfizer, do actually give you somewhat long-lasting immunity, at least 6 or 9 months, because not only of the antibody levels, again, no specific correlate of protection of if you have a certain level of antibody, because if you don't, but you have other responses as well. And we know that you have memory function in your immune system. So if you are re-exposed to that virus or that antigen, those memory cells, B cells, will start to produce antibodies more, but also those T cell responses as well.
And I think, we know that at some point with multiple vaccine candidates, we may be able to choose the best vaccine candidate for an individual person based on their coexisting disease or their age or whatever variables are important. But at the moment right now, I think we would all argue strongly that the value of getting a vaccine, even if the immunity does wane at 6 months or 9 months, is still very, very high and far outweighs any reasoning not to get the vaccine.
Yeah, and I think we should mention too just a little bit more about the immunology of that. The spike itself has different areas that your body recognizes. The antibody, the neutralizing antibody that they're talking about, that can be somewhat decreased, especially with like the South African variant, B1351, I believe. There are other regions on that spike protein that cause pretty good cross-reactivity in those T cell responses as well, because the T cells are extremely important for destroying the cells that are infected with the virus to help prevent further viral replication. So.
All right. We have a lot of people that are asking about Missouri and Kansas being at the bottom of the list nationally or towards the bottom. And they want to know if you could explain a little bit more. Is it all just reporting the numbers? Are there other reasons?
Dr. Norman?
Yeah, I can't comment on Missouri. I do work with Dr. Randall Williams. I've known him a very long time, but I don't know the answer to the question for Missouri, but I do know it for Kansas. And the answer is it's data and reporting. All these interfaces with this, and I won't go into the HL7 interfaces, but when we brought on a lot of new vaccinators, all of them have an electronic record where they put the information in, the patient-specific information. Ideally, it goes through this interface and uploads. The workaround we're doing should temporarily fix this, and then we have to go back and do a lot of cleanup. But I have a lot of confidence that as soon as we get the pipeline of data coming in, then we're just going to elevate into a very, I think, a good place in the, and there's a very small difference between the ones that separate the 10th best to the 40th best. There's a very small amount of differences on a per capita basis. Ours is data is the problem. The vaccine's getting into arms. We call people, and that's how we know that. But we had one place that had 2,000 vaccines shown as not registered. They had entered all of it in, and they thought they had done everything correctly, and it went up. We had them showing 0 as having been. So we have to go back and recover all. We have all that patient-specific information. We're not going to lose it. It's just a matter of timing. I understand it's an accountability and it's a confidence issue, but the vaccine is getting into people's arms, and I think it's been very successful. Data tracking has been a real headache.
Yeah, Lee, I'll reinforce your point about the difference between the best performing and the worst performing, if you will. If you look even at the New York Times map, the vaccine tracker map, it shades states by color, lighter green for a smaller percentage and darker green for a higher percentage. And the reality is the difference, even though they have 4 or 5 shades of green, the difference is less than 2 percentage points. Between 8.5% and 10% goes 5 different steps of color. And so the band is really, really narrow. The reality is in most places, we're talking somewhere around 10% of the population has received a first dose, and maybe 3% has received both. And that just sort of is the situation we find ourselves in based on the supply available.
We are at 10%. I don't know if I mentioned that or not, but That's available on our kansasvaccine.gov. You click right on the front of it in the middle and on the little learn more, and it takes you right to the data right there in that kind of goldenrod colored thing there. Learn more. There you go, and it takes you right to the panel. See, there it says 10%, and then it has the age distribution and who's getting what kind of vaccine and the like. Keep it, because we update that I think daily actually, or maybe 3 times a week. I'm not sure.
We have reporters and a lot of community members that are wanting to know this is a 2-part question. First part, within the 65 and plus older, the phase that we're in, a lot of them have medical conditions that they think ought to prioritize them within that group. Why do we not do that?
The local organizations can prioritize as they see fit. We do not dictate that from the county level. We do. It is true that we're following the Advisory Committee on Immunization Practices of the CDC, and that is what causes the most risk for requiring hospitalization, having severe illness and death, and the prioritization, which by the way is exactly the same as the CDC recommends. Their phase 3, our phase 3 is their phase 1C. We're in 2, that's their 1B. It's just a different numbering nomenclature. But it's all risk-based and on the probability of severe disease, hospitalization, and death.
Okay, and then Sharon, she's an example, and Caesar, there are people that, Sharon's got a son who's 50 years old that had both his adrenal glands removed, and she wants to know why he can't get the vaccine because of his risk that he has. And Caesar has cancer, and they want to know, I'm not in that current phase, but I have cancer. Why can't I get the shot? My doctor says I need to get it as soon as possible.
We might have frozen Dr. Norman. I think, those questions are fair. Yeah. They're individual issues that are very reasonable to be concerned about and to ask about. I think, we've said from the very beginning here, first it was about how the disease was transmitted and how to protect yourself, and then it was, what about mortality rates? And we've had a lot of questions that were individual in nature that may be slightly different at the individual level than they are in a population level. And that's, I guess, a fancy way of saying the CDC guidelines are focused on, from the large data sets that are available, what we currently know based on evidence puts you at a higher risk. And while there are a handful of individual, very specific things from a couple of studies that show individual diseases might put you at a higher risk, the odds ratio for severe infection and death is really the highest by far for age, not for comorbid conditions. And so that is the reasoning behind the CDC, or the Advisory Committee on Infection Practices that Dr. Norman mentioned. That's the reason for that recommendation. So I know that it's hard to hear. You might not be at as high of risk as someone else, and maybe even individually that's not true, but at the population level, that's the best evidence we have at the moment. And I can see Dr. Norman is back now. I'm not sure if he heard the question or has other things to add.
No, I don't have. I heard most of the question, and you're answered. I think that's the same thing that I would say. Sorry, I think the electrons must be moving slowly on this very cold day. I don't know why the people connect.
Everybody and everything is cold. Debbie wants to know, in Johnson County, she says the department is only vaccinating from 9 to 1. I think she means PM, not AM. And they are sending anyone over 65 to local hospitals. Read their newsletters. She says, why aren't we doing longer hours?
Well, I can tell you what I know. Based on a weekly call every Wednesday, we meet, as all of the hospital systems in Johnson County, we meet with the Johnson County Department of Health and Environment, as well as the county managers, and in some circumstances or on some weeks, members of the county commission. I don't know specifically about their hours, although I know they have identified that one of the best ways to get doses in arms and reduce crowding in vaccine locations is to partner with all 6 of the hospital systems in Johnson County to be delivery sites. And with the current supply, that does limit the hours or the number of doses that are available to the county and to others. They've asked us very clearly, though, to partner with them to take care of those patients over 65 that are already established in our system, because there's an established relationship. You know how to get in and out of our facilities. They're designed for people who might be over 65, who may have mobility issues or need someone to help them. And so those things are all reasons to consider set up an already established location rather than maybe one that's a pop-up location in a gym. And that's the reason they've asked us to participate. I have a feeling that the 9-to-1 is really based solely on supply, and that if we had more supply, they would be vaccinating longer, but I can't answer specifically for them.
If I may add, David, the reason the question comes up, why don't we set up mass vaccination sites? And a couple of reasons. We do have mass vaccination sites. We have them in Kansas City, Stormont Vale, one has a large one here. We have them all over the state, and we don't have mass vaccine. And that's why it's in smaller numbers, smaller office hours, smaller vaccine clinic hours. Why do we call it the National Guard? I'm a National Guard colonel. We do have the National Guard soldiers and airmen that assist us when we need them, but we haven't needed them because they don't bring their vaccine with them when they come. Why don't we build solid wall or tents? We don't have vaccine to put into those solid wall facilities or tents. So the constricted hours and is a phenomenon of just too little vaccine. We've done the modeling. We feel if we had 10 times the amount of vaccine coming in per week with our existing 1,058 vaccination sites, we could accommodate 10 times the amount of vaccine coming in. But as per the question, and it's a good one, we'd have to extend hours longer and then bring in some additional vaccinating volunteers and National Guard soldiers and airmen.
All right, we have 2 or 3 more questions and then we'll call it a day. Ann wants to know, she says she sees that the new infections and hospitalizations with COVID are dropping, but the national stats on the number of deaths seems to be a plateau. She wants to know, what do you think is next with this new variant?
I may start, and then actually hand it over to Dr. Norman. I have a specific question to him on this front too. So the first thing I would say is we do know without a doubt that the number of hospitalizations, the number of new cases, all of the things that Dr. Norman mentioned at the onset are decreasing. Interestingly enough, there's a lot of conversation in the population health and epidemiology communities about why that is. No doubt vaccination of healthcare workers is having an impact. No doubt the decrease in the number of long-term care facility clusters and transmission to the most vulnerable is having an impact. But we've not vaccinated enough of the general population to really have this degree of impact. So the questions about mobility, are people moving less? And the answer to that is, since the holidays, since the Christmas holiday and New Year's holiday, the answer is yes. Cold weather is also keeping people from moving, so that is helping us maybe in some small regard. There's also some evidence that masking and physical distancing is the compliance with those non-pharmaceutical interventions is better in some places. And then there's a growing theory that maybe the people that were going to get it, or the people who are, I'll say, continually behaving in a way that puts them at a higher risk, might have already had it. And so they're still out doing the same things, but they have some degree of natural immunity now, and the transmission rate is lower. And so I think all of those things are feeding into, I'm sure there are other variables as well, but all of those things are feeding into why cases are lower. But the question about deaths and the plateau of deaths is an interesting one. Number one, we're still seeing deaths being recorded from patients that had infections that started several weeks, if not months ago. Whether they stayed in the hospital for weeks or months, or the recording is just happening now. Those things are true. We know they're true when we look really deeply in the death data. The second thing that we have to maybe consider there is that even though the hospitalizations are down, over time, if we see the mortality rate, the percentage of those being admitted to the hospital that don't survive increasing, that would just tell us that not that the disease is suddenly more deadly, but those people coming to the hospital, less of them are coming for mild disease because there's less transmission in the community. And so I'm not saying that's the issue yet, but we're definitely paying attention to it because it does seem like that may be part of the story around deaths, added to the trickle-in effect that I mentioned earlier. Lee, I know there was a lot to unpack there. Thoughts from your perspective?
Well, two things. One is that for an anesthesiologist, I think you'd become a pretty good public health doctor.
Thanks.
We might have a place for you over here. But beyond that, the other thing I think has made a difference is testing. And I might use that one Ellis County young man as an example. He's an athlete, so he's undergoing routine testing. He was never particularly ill, and it was his this UK variant diagnosis in him was found through just a routine test because they were testing all the athletes. We brought in a strike team and a mobile testing lab and did a couple hundred tests. And interestingly, only one person came back positive of those 200 that were community members and contacts. And only one out of the 200 came back positive. And curiously, it was not for the UK variant. So I think testing and the wider availability of testing, and we're doing a lot of screening in schools, universities, athletics, and the like. And I think that's made at least some difference because, you know, from those, if you can find somebody, as David pointed out, if you can find somebody early on and then do the classical isolation and quarantine, contact tracing, case investigation, it makes a difference. It's worked for 500 years and it still works.
All right, Sandy wants to know, now that my husband and I have both been vaccinated, can we still potentially be asymptomatic and cause others to get the virus?
Mm-hmm. Yeah, I mean, I think the short answer is yes. There's more signals or more information out. You know, either anecdotally we saw from Israel, they believe the vaccinations are causing a decrease in the spread on an individual level, but also the population level. There was some information, I believe, from AstraZeneca that showed that they had reduced replication spread as well. So, you know, we do believe and hope that you can spread it less because of the vaccination, especially if you have that immune system response that is helping to reduce the viral replication. But I think right now the answer is still yes. We still need to wait for more data and more information on that.
Last two questions. Susan has one. She says she has to go to jury duty in 2 weeks. Her county does not require mask wearing inside the courthouse. She's worried about catching COVID. What can she do besides mask wearing to protect herself?
Yeah, that's a concern.
Yeah, I think, you know, obviously the part of wearing your own mask, encouraging the others potentially on the jury, if you're able to participate as well. The same pillars of infection prevention practices apply here. If you can physically distance yourself even from others, 6 feet or more, and the farther the better, that would be helpful. Great hand hygiene. All of the things that we've been talking about. We continue to stress this point because we know with a small supply of vaccine, these other things are going to be what keeps transmission low in our community for at least several weeks, maybe not months. And so regardless of the circumstance, jury duty or otherwise, those things are important. I think we'll continue to highlight.
Yeah, a well-fitting mask and eye protection or a face shield, I think, would help too.
All right, and last two questions in one question, and I promise I'm done. Salinas wants to know, do I have to get tested before getting the vaccine? What if I'm with infection but I have no symptoms? And then the other question is, 84-year-old woman has no internet, doesn't know how to use it. How does she get a shot?
Yeah, the answer is no. There's no minimum time between infection and vaccination, and there's no recommendation to test before you get the vaccination. So go ahead. If you have something scheduled, you're asymptomatic, you're otherwise feeling good, go ahead and get the vaccine.
As far as our 84-year-old friend and tech savviness, I think we have heard from nearly every county that we have spoken with, whether it be Sedgwick or in Topeka or the counties here in the Kansas City metro area, that the health departments will answer the phone at their main number and help anyone get on a list to get scheduled or indicate your interest for vaccination. So I'm not sure where that viewer is from, but there should be an easy way to start, and that I would say is your county health department. Of course, they may send you to another number, and we have to maybe anticipate that if, for example, the local pharmacy in a smaller rural county is the place delivering the vaccine, the health department may send you there. But you can pick up the phone and call your health department, and they'll be a great resource no matter where you're at.
Yeah, I would say start with the phone call. Start with your phone call to your physician's office, your local pharmacy, just as David said, the health department, I thought Wyandotte had just an easy 311 number even you could call, but any of those main phone numbers, there are people there who want to help you and will get you directed to the right place.
All right. Well, tomorrow we'll talk a bit about sleep deprivation, but not just in adults. We know that during a pandemic, these things impact our children as well. Our pediatrician, Dr. Stephen Lauer, will join us to talk about sleep regression in children, what's normal in circumstances like this and what's not. He'll offer symptoms to watch for and advice for how we all care for our kiddos at home. So, as we wrap up today, Dr. Norman, any final thoughts?
No, we've really covered a lot of ground today. I guess what I would say to the general public is that I understand the frustration of not having enough vaccine. We spent a lot of time with this, and the allocation method I think is sound, but look at it over the long haul, not just 1 week to the next, and we will push out the vaccine as soon as it is available.
Dana?
Yeah, to piggyback on that, thank you, Dr. Norman, for taking your time again today. To piggyback on that, we know that Johnson & Johnson's EUA has been submitted. It will be in that review process to make sure that it is safe and efficacious. And if there's a recommendation to give an EUA or to not, if it is recommended, then hopefully that will put less of a strain on our supply. That will add more supply, and more people can get the vaccine at that point.
Yeah, I think I'll add to both of those. Everyone has the same desire here, right? To sort of get this over with as soon as possible, whatever that means. And although saying we need a couple more weeks to be able to get to you individually feels probably like an eternity, we've been in this together for quite some time now, and I know it's not the answer that people want to hear, to give us a week or two to be a little bit patient, but everyone really is doing the best that they can in almost every circumstance. So keep doing the things you can do to maintain your health and the health and safety of those you care about. I think we'll end that way this morning. With all the talk of the new variants, we want to remind you why and how the pillars of infection prevention and control work. Here's a reminder in this video we dug out of the archives and lovingly call an oldie but a goodie. If you're aiming at what keeps your family safe from coronavirus, think of each of the things on the list here as a slice of Swiss cheese with the holes in slightly different spots. So physical distancing, one intervention, one barrier, but not 100% perfect. Mask wearing, another intervention, another barrier, but not 100% perfect. Hand hygiene, right? Frequent hand washing, another intervention. And then rapid testing in symptomatic patients or those who are exposed. Each of these things matters. We know that if you do them, you can keep yourself safe.